Hello everyone and welcome to the renal disorders. We're going to start talking about acute renal failure, but before we talk about disorders, let's talk about the physiology of the kidney. How does the kidney works? The functional unit of the kidney is what we call the nephron, and the nephron works the same way you should clean out your closet. What does this mean? How to clean out your closet? The best way is to get everything out of your closet, and then you start getting back whatever you need, and you will get rid of whatever you do not need. And this is exactly what happens in the nephron. This is a diagram of the nephron, and the first step of urine formation, which is everything should come out of the blood, is called filtration. Filtration occurs at the glomerulus, and by pressures everything passes out from the blood into the lumen of the nephron to be excreted as urine. This is the first step, and it is the most important step. If the rate of filtration drops, what we call glomerular filtration rate, this is renal failure. So what is renal failure? It is low glomerular filtration rate. If filtration is defective, then stuff will accumulate in the blood, and we measure two important parameters for that, which are the BUN, blood urea nitrogen, and creatinine. So filtration is the first step, and by this we mean everything should come out of the blood into the lumen. Now the second step is when you look at the stuff that you got out of your closet and you start saying, oh, I want this jeans, I want that shirt, I want this, I want that. And this is called reabsorption. And reabsorption occurs in the kidney tubules, especially in the proximal kidney tubules, proximal convoluted tubules. Like 80% of the reabsorption that happens in the kidney occurs at the proximal tubule. And we reabsorb a lot. So the daily filtration is about 180 liters, but the daily urine output is about 2 liters. This means what? We reabsorb the majority, more than 95% of the stuff that we filter. And this reabsorption, everything is reabsorbed back, almost everything, but a very important exception, creatinine is never reabsorbed back. Another process that occurs in the kidney tubules is called secretion. And what's secretion? Stuff can pass directly from the blood vessels into the lumen of the kidney tubules via this process of secretion. And the end result, the urine that gets out of the kidney, is called excretion, which is going to be the end result, the sum of these three processes of filtration, reabsorption, secretion. Now, renal failure, as I said, is low GFR that leads to accumulation of nitrogenous waste products in the blood, namely BUN and creatinine. And we call this azotemia. So what's azotemia? It's a lab diagnosis of elevated BUN and creatinine. Elevated BUN and creatinine is called azotemia. What's the difference between azotemia and uremia? When azotemia is severe enough to be associated with direct clinical manifestations of renal failure, we call this uremia. And what are the manifestations of renal failure? Imagine yourself bathed in urine. This is going to be very irritant. So imagine your body organs bathed in elevated urea. This will lead to irritation of the pericardium, pericarditis, and this will lead to defective function of platelets. Your platelets cannot adhere and prevent bleeding, and there will be increased tendency to bleed. And this will lead to defective function of the white blood cells, and there will be increased liability to infections. Let's talk now about acute renal failure. And as I said, renal failure is what? Decrease in the glomerular filtration rate, that's low GFR, that leads to azotemia, that leads to elevated BUN and creatinine. What are the clues that this renal failure is acute? The basic difference between acute renal failure and what used to be called chronic renal failure, and now we call it chronic kidney disease, is simply time. When the deterioration in the GFR occurs over hours to days, this is acute renal failure. But when it occurs over weeks, months, years, this is chronic kidney disease. And in acute renal failure, the kidney will have normal size, and there will not be any anemia, so normal hemoglobin and hematocrit, and there will be no hypocalcemia and normal calcium. So normal kidney size, normal H&H, normal calcium, all these are clues to the acuteness. And the major categories of causes of acute renal failure could be something happening prior to the kidney, before the kidney, what we call pre-renal, or something inside the kidney tubules, what we call renal, or something outside the kidney after the kidney, what we call post-renal. Now let's talk first about BUN and creatinine, about urea and creatinine. Where do we get our urea? Urea is synthesized in the liver from protein catabolism. When we eat protein, ammonia comes out. Ammonia is very toxic to the brain, so the liver takes ammonia and converts it into urea. So what are the conditions that will lead to elevated urea in your body other than renal failure? Fever, burn, steroids, bleeding into the GI, anything that produces too much protein catabolism will lead to elevated urea. The only condition where you get low BUN is when the factory of urea is not functioning in liver failure. The most important thing to know about urea is in the kidney, urea is filtered and reabsorbed. Urea is filtered and reabsorbed. Creatinine, which comes from muscle catabolism, what are the non-renal causes of increased creatinine? Some drugs that prevent its secretion, like cimetidine and trimethoprim. And decreased creatinine is related to decreased muscle mass, as in elderly. Females have lower creatinine than males. Elderly have lower creatinine than adults. And the most important thing to know about creatinine, how does the kidney handle creatinine? In the kidney, creatinine is filtered and secreted, but not reabsorbed. And this is of utmost importance. Normally, the level of BUN is around 15 milligram per deciliter, and the level of creatinine is around 1. So the normal BUN to creatinine ratio is 15 to 1. We make use of this ratio to differentiate between the three different categories of acute renal failure. So in pre-renal Azo Tinea or pre-renal renal failure, which is simply low flow states, hypotension, hypovolemia, the BUN to creatinine ratio is higher than normal, and most often it's even higher than 20 to 1. In renal azotemia, when the defect is inside the kidney tubules themselves, the BUN to creatinine ratio is lower than normal, less than 15 to 1, and it is closer to 10 to 1. In post-renal azotemia, the BUN to creatinine ratio is again higher than 15 to 1. Now, let's talk about the different types and causes of acute renal failure. We have three categories. We have the pre-renal, intrarenal, and post-renal. Whenever the problem is outside the kidney, it's either pre-renal or post-renal. Actually, there is nothing wrong with the kidney itself. Yes, the patient has renal failure, but not because that kidney is defective. You can take this kidney and transplant it in another person and it's going to work just fine. But in intrarenal renal failure, here the kidney itself, the nephron itself, the tubules themselves are defective. So pre-renal renal failure, the mechanism is low blood flow getting into the kidneys, low perfusion. And when you have low perfusion pressure, you will not be able to filter. What's low filtration? It's renal failure. And the causes of pre-renal renal failure, any condition that leads to hypotension, hypovolemia, heart failure, any condition that leads to hypovolemia, constrictive pericarditis, hypoalbuminemia, this will lead to relative hypovolemia, and renal artery stenosis, this will lead to decreased renal perfusion. Let me talk about post-renal and then we'll shift to the intrarenal causes. The mechanism of post-renal is simply what? Obstructive uropathy. There is an obstruction in the urinary tract. Stone, stricture, tumor, obstruction, stone, stricture, tumor, obstruction. This will cause back pressure into the kidney. And here, the obstruction has to affect both kidneys in order to get renal failure. So what's going to cause renal failure? Is it a big, huge kidney stone on one side, or just small stone in the urinary bladder. It is the small one in the urinary bladder. Why? Because the back pressure is going to affect both ureters, will affect both kidneys, and the obstructive uropathy has to be bilateral, not unilateral. Some of the causes of this obstructive uropathy are BPH, benign prostatic hyperplasia, cervical cancer, stones, neurogenic bladder. Now let's come to the important category of the intrarenal causes of renal failure. Here the mechanism is problem with the nephron itself, the glomerulus, the tubules. And some of the causes, the most important cause is nephrotoxic medications. Famous groups of medications that damage the kidney are the aminoglycoside antibiotics, gentamicin, tobramycin, amikacin. Vancomycin is also another nephrotoxic antibiotic. Acute tubular necrosis that follows states of very low, prolonged low high blood pressure. Very severe hypotension for long time will lead to tubular necrosis. It's something like the heart attack. This is the kidney attack, the tubular attack. The tubules do not get enough blood and they die. Contrast agents, the fastest cause of acute renal failure is contrast agents. And this will damage the tubules. Chemotherapeutic agents, some chemotherapeutic agents like cisplatin. An interesting cause of acute renal failure is allergic interstitial nephritis, and here there is an element of allergy, and this is the only case of renal failure where you're going to see rash and eosinophils in urine. So you get in allergic interstitial nephritis fever, rash, eosinophils in urine, and we can detect the eosinophils in urine by a special stain called Hansel stain. Allergy to what? The most notorious medications that cause this type of allergic interstitial nephritis are penicillins, sulfa, phenytoin, allopurinol, quinolones, and rifampin. A last cause of acute renal failure due to intrarenal damage is rhabdomyolysis. What's rhabdomyolysis? Destruction of muscles as in crush injury, and also as in recent use of statins. And here actually the patients will die of severe hyperkalemia because when you destroy muscles, a lot of potassium escapes out of muscles. So the categories of renal failure are pre-renal, renal, and post-renal. How to differentiate between these categories? So we can divide these three categories pathophysiologically into two big categories. One category, the problem is outside the kidney, and we're going to call this category in general pre-renal. Here the problem is not in the tubules. And the other category is when you have the problem inside the tubules, and we're going to call this category renal. So the pre-renal, actually it includes the truly pre-renal, something before the kidney, and even some glomerular problems. We can consider the glomerulus as part of the blood, because actually the glomerulus is just capillaries inside Bowman's capsule, which is the first part of the nephron, and also the post-renal causes. What's common in this category? In this category, the common thing is the tubules are normal. The tubules are normal. And what's the function of tubules? Reabsorption and secretion. Hence, here we have normal reabsorption and secretion. As a matter of fact, we even have supernormal, augmented reabsorption. Why? Because the tubules are normal and the glomerular filtration rate is low, so the flow inside the tubules is slow, and the tubules are normal, so you're giving the tubules more time to reabsorb. It's like when I give you 30 questions in 30 minutes, you will get some score. But if I give you 30 questions in 1 hour, you will do better. Why? Because you have more time. And here the tubules have more time. On the other hand, the category of renal, intrarenal causes, here we have damaged tubules. Damaged tubules means what? No reabsorption and no secretion. So pre-renal renal failure, supernormal reabsorption. Renal failure, no reabsorption. We're going to discuss how to differentiate between these two categories based on how much sodium do we have in urine, how much water do we have in urine, and the BUN to creatinine ratio. In renal failure, you do not reabsorb. So what do you expect sodium to be? Normally, we reabsorb like 99% of the sodium that we filter. Now, we will not reabsorb. So you're going to get high urinary sodium and high FeNA. What's FeNA? It's fractional excretion of sodium. What's that? It is the percentage of the filtered sodium that we lose. Normally, it is 1%. We only lose in urine just 1% of the sodium we filter. But in renal failure, FeNA goes up and urine sodium goes up. On the other hand, in renal failure, urine sodium goes down and FeNA goes down. So sodium in urine is one parameter that we differentiate between these two conditions. Also, water in urine. In other terms, when you have too much water in urine, that's what? Dilute urine. When you have too less water in urine, that's what? Concentrated urine. So simply, we assess the amount of water in urine by measuring the urine osmolarity and specific gravity. So again, in renal failure, you lose a lot of water in urine. So your urine is dilute, you get low osmolarity, low specific gravity. Whereas in pre-renal, you reabsorb water back, you do not lose water in urine, so you get high urine osmolarity and high specific gravity. Finally, we come to the BUN to creatinine ratio, and as I said before, in renal failure, the ratio is higher than normal, usually even more than 20 to 1. In renal failure, the ratio is closer to 10 to 1. Finally, what's this urinary sediments? These are some remains of cells, some granules that we can find in urine. In renal failure, we find hyaline casts. In renal failure, we find the muddy brown or granular casts. So, to summarize again, the labs in acute renal failure: 2 labs for sodium, urine sodium, and fractional excretion of sodium; 2 labs for urine water, urine osmolarity, and specific gravity; the BUN to creatinine ratio, and the urine casts, sediments, blood cells will point to intrarenal pathology most of the time.